Hello everybody, today we are going to see together the course about tuberculosis. So what is tuberculosis? It is an infection due to the Koch bacillus, which is very prevalent in the world. It's a real public health problem in the world, and especially in the developing countries. The lungs are commonly involved, and we have some clinical and radiological signs that suggest the diagnosis, but the confirmation is bacteriological. In the world, according to the World Health Organization in 2019, we had 10 million new cases with 14% of lethality. In Morocco, in 2021, we had 29,327 new cases, and the patients were mostly aged between 15 and 40 years old. We had a significant progress in the treatment of the disease, with a decrease in incidence by 35% and mortality rate by 68% over the last 30 years, with a therapeutic success around 90%. We have a strategic plan to combat tuberculosis in the hope to eradicate it by 2030. So what is the pathogen responsible for this disease? We have the tuberculosis complex and mostly Mycobacterium tuberculosis. We have also some other mycobacteria like Africanum and bovis, and really what we call atypical mycobacteria. Avium, Xenopy, Kensaci, they are often non-pathogenic. Persons present with some clinical manifestation of tuberculosis, and they occur among patients who had immunodepressions or in countries with low tuberculosis prevalence. As we have said, the most common agent is Mycobacterium tuberculosis. It is a straight and slightly curved bacilli with 1 to 10 micrometer long by 0.2 to 0.6 micrometer wide, immobile, forming neither spores nor capsules, and it can be isolated or grouped in clusters, groups, and twists. It is an anaerobic bacteria which is colorated by Ziehl-Neelsen staining. It is heat sensitive and acid alcohol resistant, and this resistance is for coloration. The bacteria is dead when we have acid or alcohol, but the wall still colorated in red even if we have acid and alcohol. The bacteria has a slow growth with a culture on special medium called Lowenstein-Jansen, and this slow growth because of the slow multiplication that take approximately 20 hours. That's why when we are going to give some therapeutics, we are going to give it once a day and for a very long time, approximately 6 months. What is the reservoir of this bacteria? Mostly it's human, and very rarely small mammals like cats, dogs, and large livestock mammals can become infected and vectors themselves. We have in the same patient, we can have 4 population of the bacillus, but we have what we call the population A, which is responsible for a high bacterial multiplication. We have the populations B and C with a medium bacterial multiplication, and population D which does not multiplicate. And when we are going to give medication, they will focus target the population A, B, and C, and this population still here even after treating a patient. What is the source of infection? Mostly is aerial. The patient is infected by another patient who has pulmonary tuberculosis by coughing and sneezing, and they have to have a close and prolonged contact. Sometimes it can be digestive, and especially for Mycobacterium bovis. It is very prevalent among children, and it is responsible for lymphadenopathy tuberculosis and not pulmonary tuberculosis. And very rarely, the skin can be the source of the infection. As we have said, when we have an infected person while sneezing, coughing, speaking, laughing or shouting, we will have some dropped nuclei, and the patient who is close to him will inhale these nuclei, and these ones will go to his lungs. But not everyone who is exposed to an infectious TB patient will become infected by that tuberculosis. The probability that TB will be transmitted depends on 4 factors. First, the infectiousness of the TB patients. Second, the environment in which the exposure occurred. For example, if we have a sunny house, an airy house, the risk is minimal. The frequency and the duration of the exposures. As we have said, we have to have a close and prolonged exposure to have the risk to develop this infection. And 4, the susceptibility for the exposed individuals. What is the pathogenesis of the disease? When a person inhales that air that contains that dropped nuclei, most of the largest one will be lodged in the upper respiratory tract, where the infection is unlikely to develop. However, the smaller ones will reach the small air sacs, the alveoli, where infection will begin. So, when these small particles, arrive to the alveoli, they will have favorable conditions. As we have said, the bacilli is aerobic strict. They love air. So in the alveoli, we have air. They begin the multiplication. So they will be phagocyted by some alveolar macrophage and dendritic cells, and some of these will be transported to the lymphatics to the regional lymph nodes, and we will have some selection and clonal expansion of some specific T cells, and those T cells will leave the lymph nodes toward the initial focus, which is the alveoli. There they will have to limitate the Koch bacillus multiplication, and this local inflammation is what we call the enucleation chancre. And this is the characteristic histological lesion, which is epithelial giant cell granuloma containing quiescent bacilli. The evolution will be even caseous necrosis, a sclerosis, or a calcification. As we have said, when we have a bacilli, it will be phagocyted by a macrophage, and it will remain replication in the macrophage. We have 2 cases. Even the bacilli will be spread in the body, or the macrophage will go to the lymph nodes, and we have some specific selection of some specific T lymphocytes. These T lymphocytes will come back to the lungs, and they will stop the spread of this bacilli, and here we have the enucleation chancres. Sometimes we will have the evolution even is caseous necrosis, and in this time we will have the spread of the bacilli, or we will have a calcification, and the patient remain having only an infection, not a disease. So how does the tuberculosis bacillus reach other organs than the lung? As we have said in the pictures before, in the alveoli, some of the tubercle bacilli will be killed by macrophage, by others will multiply and enter in the lymph node and the bloodstream and spread through the body. They will reach any part of the body, but more likely the upper part of the lungs, the kidneys, the brain, and the bones. Within 2 to 8 weeks, the body immune system usually intervenes, halting multiplication and preventing further spread. At this point, the person has latent TB infection. As we have said, that is the inoculation chancre. It's the primary laser, and sometimes we will have the spread of the disease when we have the caseous cavitations and spread by the bloodstream or the lymph nodes. So how does the tuberculosis bacillus manage to create a new source of contamination? Some people with latent tuberculosis infection will develop the tuberculosis disease later, and that can be even when the immune system cannot keep the tubercle bacilli under control and the bacilli will begin to multiply rapidly, or we can have an exogenous reinfection with a massive contagion. So, what is the risk of infection progressing to a disease? So, when a patient has an infection, it is rarely, if he had no immunosuppression, to develop the disease, and mostly 90% of the patients will remain free of tuberculosis disease for the rest of their lives, and only 10% will develop the infection sometimes in their lives. That's just what we have said. When a person is infected, 19 to 90% he will not develop the disease, and 5 to 10% he will develop an active tuberculosis. So what we have to remember, we have 3 stages of the disease. We have what we call tuberculosis infection. It's the first contact between the body and the Koch bacillus. It's what we called previously primary infection, and it's what we call the primary infection, and it is responsible for the inoculation chancre. Second, we have the tuberculosis disease. It is the secondary manifestation of Koch bacillus, and between these tuberculosis infection and disease, we have what we call latent infection of tuberculosis. It is a period between tuberculosis infection and tuberculosis disease. So, what are the risk factors to develop the disease? We have what we call some contributing factors, like precarious living condition, malnutrition, poorly lit, poorly ventilated housing, promiscuity, also toxic habits, the extreme ages. Certain diseases are responsible for immunosuppression, like HIV, diabetes, lymphoma, transplantation, chronic renal failure, and also certain treatments like immunosuppressant, corticosteroid therapy if it is taken for a long time, and chemotherapy. And we have some population, we had a big risk to develop the disease, and we have to screen them for the disease, for the infection, like contact subjects with pulmonary or with person who had the pulmonary infection, people living with HIV, renal failure patient on hemodialysis, subjects who are a candidate for treatment with anti-TNF-alpha, which is an immunosuppressor, patients preparing for an hematological or organ transplant, and celiac patients.